Welcome back to Emergency Insights. I'm your host, James Carter. Today we're discussing a critical topic in cardiology and emergency medicine, blood transfusion in patients with acute myocardial infarction. We're joined by Dr. Amelia Wu, a specialist in evidence-based medicine. Dr. Wu, thank you for being with us.
Thank you for having me, James. It's a pleasure to be here.
Dr. Wu, let's get straight to the point. The AABB recently released new recommendations on this topic. Can you summarize the core PICO question they addressed?
Certainly, James. The central question focused on hospitalized patients with acute myocardial infarction, or MI, and anemia. The intervention was a liberal transfusion strategy, meaning transfusing patients when their hemoglobin was below 10 grams per deciliter. This was compared to a restrictive strategy, which is a lower threshold, typically below 7 grams per deciliter. The primary outcomes they were looking at were 30-day mortality and recurrent MI.
And what were the key findings of this AABB guideline? What did the data reveal about these two strategies?
The findings were quite nuanced. The liberal transfusion strategy showed a numerical, but not statistically significant, decrease in 30-day mortality and recurrent MI. This means there was a trend, but we can't be confident it's a true effect. On the other hand, and this is a crucial point, the liberal strategy was associated with a statistically significant increase in serious adverse events, such as transfusion-related circulatory overload and lung injury.
That's a significant finding. So, a potential but unproven benefit against a clear, measurable harm. Given this, how did the AABB rate the overall certainty of the evidence, and what was the main reason for that rating?
They rated the certainty of the evidence as low. The primary reason for this was the lack of statistical significance for the key outcomes of benefit, the reductions in mortality and recurrent MI. When you see a trend but no statistical significance, it reduces confidence in the effect size. This, combined with the clear signal of harm, led to that low rating.
The guideline relies heavily on the MINT trial. Could you explain why a single high-quality RCT wasn't enough to provide a higher certainty of evidence?
The MINT trial was a landmark study and certainly the cornerstone of this guideline. However, even a large, high-quality trial has its limitations, and in this case, the key outcomes, mortality and recurrent MI, did not reach statistical significance. The guideline's overall rating is based on a synthesis of all available evidence, and when the most robust study doesn't show a clear, statistically significant benefit for the primary endpoints, the certainty of the overall recommendation remains low.
It seems like a classic EBM dilemma. How does the guideline translate these findings into a clinical recommendation? What should a provider do at the bedside?
This is where it gets interesting. The guideline conditionally recommends a transfusion threshold of 10 grams per deciliter. The key word here is conditionally. Because the evidence is of low certainty, it's not a firm mandate. It requires clinicians to use their judgment and engage in shared decision-making with the patient. It's a risk-benefit discussion. We must weigh the potential, but unproven benefits against the definite risk of transfusion-related adverse events.
And what about the other aspects of transfusion in this population? Are there any strong, universally applicable recommendations?
Absolutely. The guideline strongly emphasizes strategies to reduce the need for transfusion in the first place. Things like avoiding unnecessary blood draws, which can be a significant source of iatrogenic anemia, are crucial. It also highlights the importance of using restrictive transfusion triggers for other indications and being vigilant about the patient's overall fluid status. These are universally applicable principles of good practice.
In a nutshell, what's your final EBM take on this guideline? Is it a strong recommendation or more of a clinical judgment call?
I would rate the overall EBM strength as weak. While the guideline is based on a systematic review of the best available evidence, the core outcomes of benefit were not statistically significant, and there was a clear signal of harm. This makes the recommendation a clinical judgment call rather than a clear mandate. It appropriately empowers the clinician and the patient to make a decision together, considering the individual clinical context and the patient's preferences.